Good afternoon, everyone, and welcome back to my page. So this video is a part two to an early video that I did on depression and suicide. And this topic is a very, very sensitive topic, yet it's very important. It needs to be discussed. And I wasn't able to complete this topic. I wasn't able to complete discussing this topic because I was in a rush. I was actually headed to a meeting when I did the first part to this topic. So I decided I'll come back today and revisit this topic and really go into detail talking about depression as it relates to suicide, or suicide as it relates to depression, because there is a correlation between the two. In fact, suicide, when you look at suicide, people who commit death by suicide, the majority of people who kill themselves are usually depressed. So the precipitating factor of suicide for a lot of people is depression, unfortunately. And I'm going to read to you guys some of the symptoms that people who are depressed experience. Depression, in fact, is a very common mental illness in America, in the United States. Is one of the most commonly diagnosed mental illnesses that we have. Depression is diagnosed more than any other mental illness, next to anxiety. And I know a lot of people tend to think that, oh, it's just that people are lazy. Like, I think when you look at a person who is depressed and the external representation of what depression looks like, sometimes it's interpreted as laziness. But here are the symptoms. So number one would be sadness. You just do not feel good. You feel sad. You have they call it depressed mood, because depression is a mood disorder. So it affects the way you feel. There's a disturbance in your sleep patterns. So some people who are depressed may sleep more often, like 10, 12 hours a day. Some people who are depressed may not sleep, as much, as often as they should. I think a good amount of sleep is about 8 hours a day for adults. So there's disturbance in sleeping patterns, there's disturbance in eating patterns. People tend to eat more or less. It can go in either direction. But I think the more significant thing is all of these are factors, all these are symptoms of depression, of major depressive disorder. But some of the key indicators that really point to depression are loss of energy. So where you feel fatigue, you just don't feel up to par, And I'm going to talk to you guys more about, like, in what types of situations, what type of scenarios will you find depression in people? Because I think that it's a really common issue that you see in people, and it's often overlooked for various reasons. So I'll go into that next. But there are feelings of worthlessness. So you have low self-esteem. You have an inability to concentrate, or diminished ability to concentrate. You can't focus, on things that you need to be focused on. Whether you're in school, you're a student in school and you're trying to focus on your work, you're having trouble focusing. You have trouble making sound decisions. You have recurring thoughts of death or suicide. And there is an issue with, when you have a lack of appetite, it usually affects your weight. So weight loss is definitely an issue. Weight loss or even weight gain is one of the symptoms of depression. So I think when people think about, depression, they think about, oh, that person, is just not motivated. And lack of motivation is definitely a symptom of depression. So you see someone who, I think the thing about these symptoms, right? We all sometimes experience these symptoms. It becomes a diagnosis when it is affecting a person's daily functioning. And not only that, but when these symptoms persist, they have to persist for a certain period of time. In the DSM, I believe the threshold is 6 months. But even if you see a person who has these symptoms consistently, where They feel sad. They have a lack of interest in daily activities. They have changes in their appetite and their sleep patterns. They don't feel happy. It's like the world, everything around them can be perfect. It can be a beautiful day outside. Everything seems to be going okay externally, but inside, this person just cannot get up the mood to feel good inside. That can point to depression. It's such a common problem. I think that it's become normalized to the extent that people tend to overlook it. But there's so many people who are walking around depressed, and not only that, but they're functioning. So although one of the criteria to meet the diagnosis for major depressive disorder, according to the DSM, the Diagnostic and Statistical Manual for Mental Disorders, published by the APA, American Psychiatric Association, yes, you have to have these different symptoms, but I think that it often gets overlooked because so many people are experiencing these symptoms. You look around and you see that people are still able to go to work, people are still able to go to school, yet they are endorsing such symptoms. Yet you see an external presentation of these symptoms. When you look at a person, they look like they don't have any injury. They look like they are feeling down and out, like there is a lack of hope. And hope is a really lack of hope, right? A feeling of hopelessness is the biggest predictor of suicide in patients who are depressed. So when you see a person who has all of these symptoms, and it really only takes 5 according to the DSM. So if the person is feeling sad, they're feeling hopeless, you notice changes in their eating patterns, sleeping patterns. They have feelings of worthlessness. They have recurring thoughts of suicide. That's not a good thing. Actually, we're just getting started, Scrawny, so you didn't really miss much. I just kind of gave everyone an introduction to what major depressive disorder is, how it's classified in the DSM. The DSM is a manual that mental health professionals use, clinicians use, so psychiatrists, psychologists, doctors, we use this manual to conceptualize symptoms that clients may come into our office with. And not only that, but the DSM is beneficial because it allows us to communicate. So it gives this common language where we're able to communicate and discuss, across different providers, what's going on with the patient. Yes, I think, the downside to these labels, people talk about the stigmatization surrounding labeling a person with a disorder. But I think the benefits outweigh the disadvantages, because if you can identify what a person is experiencing, what a person is going through, then that identification and being able to understand it can point you in a direction of treatment and how you're going to go about working with that person and getting help. People overlook mental health conditions, period. Absolutely, but this topic is on depression and suicide because suicide is a huge issue. And according to statistics, men die by suicide 3.5 times more likely than women. So men are essentially more successful at committing suicide. They commit suicide more often than women. However, women attempt suicide more often than men. And do you guys know how many suicides occur every single day? Now, when I did this research, because like I said, this is a part 2 to the video that I did a couple days ago. You guys can go back and watch part 1 to this video. But when I did the research, the number that I got was 121. So within a couple days, you see how fast the numbers can change and statistics can change. So just within a couple days, that number has gone up to 123 suicides on average per day. That is a lot of people killing themselves. And do you know what race, what demographic of people commit the most suicide? You guys probably already know, but it's white males. White males account for 7 out of 10 suicides. These are averages. It's unfortunate, it's really not a race issue. So, it's not about, oh, white people this and black people that. Anybody can be at risk for suicide, just as anybody could fall victim to depression or any other mental illness, So none of us are immune to these mental illnesses. And it's unfortunate because, like someone already pointed out, these issues, these illnesses, these symptoms get overlooked. People carry on as business as usual because they have bills they have to pay. They have to go to work to earn a living to pay their bills. And I think it's really helpful to conceptualize depression within certain contexts, so we can really understand the nature of how depression comes to be. Because depression, let's say in a mother who just had a baby, which they call postpartum depression, it's going to look different than depression in a person who is a veteran of the U.S. military. The outward expression of those symptoms and even the internalization of those symptoms will look different. There are all different kinds of contexts for how depression can evolve, unfortunately. That's why I think it's so common. People, essentially what I'm saying is people get depressed for many different reasons. A lot of times depression is linked to loss. You can lose somebody that is close to you, and then that can trigger symptoms of depression inside of you, Because what happens if someone dies and you're really, really close to that person, whether they die or you lose them by breakup in a relationship, it's still a loss, and it's going to trigger something inside of you. You're going to have feelings of sadness, whether it gets to the extent of major depressive disorder in terms of the feelings of hopelessness and helplessness and lack of interest in daily activities and it affecting your concentration, ability to pay attention, because this thing is on a spectrum. Depression is on a spectrum. So you have mild depression, moderate depression, severe depression. You have people who are really chronically depressed, so to the point where they cannot get out of their beds. To get out of bed and to go brush your teeth, just to say getting out of bed. Don't even take it to the point of brushing your teeth, going to the bathroom and getting the tube of toothpaste and pulling out your toothbrush and squeezing the toothpaste on your toothbrush. For a depressed person, just getting out of bed, just being able to sit up in the bed, put your feet on the floor, stand up. For a person who is depressed, that's a big thing to be able to do that. For a person who's chronically depressed, not just depressed, but we're talking about on the severe end of the spectrum. So they're severely depressed, they're chronically depressed to a point that it has caused a significant impairment in their daily functioning. Being able to do daily activities like getting up, washing, taking a bath, brushing your teeth, doing hygiene, those are daily activities. Going to work, going to school, taking care of your kids if you have kids, walking your dog, things like that, cooking, those are daily activities. When a person is affected by depression, those daily activities become compromised. That's one key indicator how you know a person is being affected by depression. They're suffering from depression because they just don't have the energy within them to do that. They lack the motivation to do that. And people who are healthy and are high functioning, they have, it's intrinsic within all of us, healthy individuals, where we have this inclination to go wake up in the morning and to be productive citizens in society. But people who struggle with depression, that inclination over time get sucked away, unfortunately, you know? And depression is a concept that can be understood in many different ways. So psychologically, we know what happens to a person when they are depressed. You know, they feel sad, they feel hopeless, helpless, you know, lack of motivation. That's a psychological conceptualization of depression. But also alongside the psychological conceptualization is the biological aspect of depression. You know, the neuropsychological aspect of depression, because there's something going on in a person's brain when they are depressed. That's why one of the treatments that a lot of clinicians and doctors rely on to treat patients with depression is medication, you know, because we know that medication is highly effective. It's highly effective because it automatically takes effect on a person's brain, which essentially, you know, it takes effect on the person's mood and a person's thoughts and a person's behavior overall. So if a person is chronically depressed and they're coming into a therapist's office seeking help, more often than not, that therapist is going to recommend medication. Whether you're seeing a therapist, whether you're seeing a doctor, psychiatrist, or a physician, a medical doctor, they are going to recommend medication. Because the theory is that if a person is chronically depressed, what that means is that they have a deficiency. There's a deficiency in the brain, because we know that depression is linked to certain neurochemicals in the brain, such as serotonin, dopamine. When a person has a deficiency of serotonin in the brain, that's where the fatigue comes from. That's where the lack of motivation comes from. Serotonin is what gets us up. It's what makes us feel like doing something. You know, when you have this deficiency in your brain, it affects so many different other aspects. So you see how what we put, not only what we think, but what we put into our bodies is so important. What we eat, what we consume, whether it is food or drugs, is so important because it affects us on a biological, neurological, psychological, behavioral aspect. And I know there are some people who are opposed to medication. So they're like, you know, yes, I realize that something is wrong with them, but they're less likely to consult with medication or to take that route because of the damaging effects of medication. You know, medication isn't all what it's cracked up to be, right? On one hand, it can be very effective and you can see some immediate results when you pop a pill. But on the other hand, medication cannot be a good thing because it has the side effects that comes along with it. And you know that when you take medication, you're changing your brain chemistry. You know, a person's brain is never the same after they take medication. They're introducing these chemicals, these substances in their body that alters their chemical makeup of their brain, that alters the normal functioning of the way their body, their mind, their brain works. But it's an alternative. I want to talk to you guys about some of the contexts that I've worked in where I've actually treated and worked with suicidal patients who had suicidal ideation. As you guys may or may not know, I'm in my second year of my PhD program in clinical psychology, training to become a clinical psychologist. But before I started my PhD program, I also had much exposure to a variety of different clients with mental illness, people who have mild to moderate to severe mental illness. A lot of my experience has been working with people with severe mental illness. So I remember this is like 15 years ago when I first started out in the field and I was working towards my bachelor's degree at Florida State. I remember taking a job at a psychiatric hospital. And this was in Tallahassee, Florida. And I got a chance to work with a variety of clients. And usually when a person is in a psychiatric hospital, chances are they're struggling with something that is more severe. So it could be psychosis, it could be schizophrenia, you know, it could be suicidal ideation. A lot of times that's what they're there for, you know, because they have posed a danger, a threat to themselves. So they have to go into this secure environment where they can be stabilized, where they can get the proper treatment that is going to get them back to a point of stabilization. And usually that period lasts 72 hours. So that's 3 days that they are there, or they are getting their work. They're actually under the auspice of a treatment team, which includes a psychiatrist, sometimes psychologists, nurses, therapists, a group of people who have been trained and are licensed to handle and work with this issue that this person is experiencing. And I remember one of the clients was a very young kid, Actually, at the time, it was like the same age as me. It was very eye-opening, because I don't think up until then I had come across someone who was suicidal. And so I probably was maybe 19 or 20. I was young, probably 20. And I remember when I was working at the psych hospital, the kid got admitted because, and I keep saying he's a kid because I'm much older now, so I'm like in my mid-30s, but he was, like I said, the same age as me. He was a college student, football player, and it's just a sad story, because you take a college student who is working towards becoming something. He's just at the cusp of developing himself, developing his identity, as a person, and then within his career. Just beginning, he's just launching, right? Not only that, he's also a football player. He's into sports. Yet, he is taken to the hospital where I work for suicidal, not just ideation, but making a suicide attempt. And what he had done was he took a very thick rope and tied it around his neck. Very, very tight. And hung himself. He hung himself. But he did not succeed at it. To succeed, essentially, in this context, is to commit suicide, to die from suicide. He didn't die, but it messed him up, because when he got to the hospital, he had these marks around his neck. I can never forget that. There were like engraved marks around his neck, the entire part of his neck, essentially. Not just one part, but the entire part of his neck had imprints of the rope, and there was red, and there was scars. You can see some of the meat, you can see some of like tissue scarring around his neck, because he really wanted to die. He wanted to die, but the method that he chose obviously wasn't successful. So he ended up in the hospital, and I remember talking to him, and he seemed so smart. He seemed like, out of all people, why would you do this? Why would you do this to yourself? And that's not necessarily the approach that I took in working with him, but in my mind, it will, in anybody's mind, it'll make you wonder, what is it? Why this, and why now? He's so young. But that's the thing about suicide. It's like, there are signs, and that's the reason why I'm doing this video, because before a person gets to the point where they say, you know what, I don't want to live anymore, there is a progression that happens through that person's life, within that person's life, that leads them to the point of saying, you know what, I made this decision. I don't want to live anymore. Depression, I know I'm titled this video, Depression and Suicide, but depression is not the only precipitating factor or contributing factor that leads to a person to commit suicide. There are other issues. Bipolar is one of them. So bipolar is a combination of depression and mania. And it's not when a person necessarily is depressed in the context of a person having a bipolar disorder that they decide or attempt suicide when they're depressed. A person who is bipolar is more at risk for committing suicide during their manic phase. That's when they have this burst of energy. They actually have the energy to go out and kill themselves. When a person is severely depressed, they barely have enough energy to just get out of bed and stand up, let alone kill themselves. Not to say, because again, like I said, depression is the leading cause of suicide. So it's not to say that a person who is depressed can't commit suicide, but it's just to make things, to simplify things and to make it more understandable for you guys. When a person is bipolar, so that means that they have episodes of depressive states, and then they have episodes of manic states, and they kind of vacillate between the two. It's a really complicated issue. People who are borderline also are at risk because they have issues regulating their mood, and they have issues regulating their impulses, So they'll get an impulse to say, fuck it, and go, and they act on those impulses. Not that we all have impulses, right? So it's not necessarily the impulse that leads them to do that. It's the lack of regulation of that impulse, and it's very unfortunate. And I remember before leaving Tallahassee, I worked at a suicide prevention hotline. I was a crisis counselor on the hotline. And I remember at the time when I was working, the hotline that I'm talking about is called 211. But at the time, it was more of a localized hotline. So they had it in certain cities. It wasn't this national hotline that people can call, which I'll come to you guys and talk to you guys about a little bit later in this video. And it's a local hotline. People could call to get us help with just basic needs. So if they need housing, food, counseling, we would provide them with resources. We would connect them with resources in their area according to their zip code of places, agencies that they can call or reach out to get the help. Not only did we provide, resources and referrals, but we also did short-term crisis counseling over the phone. And being that it wasn't just a crisis hotline, it was a suicide prevention hotline. So you have people who would call the hotline really who were thinking about killing themselves. They were contemplating killing themselves, and our job was to kind of talk them out of it and keep them on the phone long enough to be able to give them some resources and link them to somewhere where they can get the help. Depending, and this is what the tricky part of the job was, because depending on what they said, we have to assess the severity over the phone of how likely they were to commit suicide. Because we don't want to hang up the phone with a person who is pretty much at the brink of pulling the trigger and killing themselves. Definitely want to do that. So our job, we had to decipher, okay, how likely is this person to commit suicide? Is this person safe to just be able to, talk to in a short-term crisis counseling format and give them some resources over the phone? Or does this person need to stay on the phone with me and I need to get this person's address and send the response team? They actually have a crisis response team that goes out into the neighborhood and works with people who are suicidal. They usually try to de-escalate the situation, and if they are able to successfully de-escalate, then good. Oftentimes that's not enough, so they have to take the person to a hospital, a psychiatric hospital, which is where I worked at, one of the places where I worked at. And I think it can be really challenging, because as a person on the other side of the table, working with someone who is suicidal, it's like you have to be able to remain calm with yourself. So you may have a person who has completely lost it, They're like, I don't know what I'm going to do. And they're bawling and crying and screaming. And to a certain extent, they may be threatening to kill themselves. Like, I can't do this anymore. I'm about to do it. I'm about to overdose with it. Or even they may have already attempted it. So you have, like, for women who attempt suicide, it's often said that women, their method of choice is taking pills to end their life. And so let's take, for example, you may have a woman, who just wants out of this abusive relationship and decides, I'm going to just take all these pills to remove myself from this situation. But what if she survives? She takes the pills and she survives. Now she's fucked up. She decides to call to get help, you know, at that point, at the point that she's already attempted suicide, it's like, okay, she needs to be in a hospital. So being able to, as a crisis counselor on the other side of the phone, being able to decipher where a person is, you have to know what questions to ask, you know. And one of the important questions is, number one, have they attempted the suicide before? Because it puts them at a higher risk if they have previous attempts. And also, if they have a method, do they have a plan? That is so important. The person is saying, you know what, I'm thinking about killing myself. I want to kill myself. Because I think people sometimes say that all the time. You know, they'll allude to the fact that, oh, I don't want to live anymore. So being able to decipher between if their suicidal ideation is more passive or is it more of an aggressive act? Like, are they really contemplating suicide? Because a lot of times it's more passive. So they'll be like, I don't want to live. But then you go to ask them, okay, you don't want to live. So how long have you been thinking about this? And I'm like, off and on. You know, I think that the world would be better without me, right? They may say something to that effect. And then you ask, okay, well, do you have a plan? And then they say, well, no, not really. I just think that the world would be better without me. So when a person says something like that, it can be understood that that person is low risk suicide, right? They don't have a plan. When a person is really seriously contemplating suicide, they got that shit mapped out. You know, they have a plan, they know when, they know where, and they know how. You know, and amazingly, you have people who are contemplating suicide. They will, if you ask them, they will tell you. You know, if they trust you enough, they will tell you. And not only that, but if they want to live, because the thing about mental illness, right? And when a person has become destabilized to the point where they are thinking about killing themselves, the thing is that they are really wrestling with two different worlds within in their psychology. So it's like part of them wants to die, but part of them wants to live. And the goal of a clinician, a skilled clinician, is to really tap into the part of them that wants to live. And you can listen and read between the lines to see if a person wants to live or if they want to die. It's a fine line, but you can find it. And being able to find that, meet that person where they are, find that part of that person that really wants to live, then you can save a life. So that's just one example, you know, of a context in which I've worked at, and working at the psychiatric hospital and also working for the crisis hotline. But I also, when I moved back to my home city of Jacksonville, Florida, I also worked at another psych hospital where I met another client who had attempted suicide. He was a white male, just as the one previously, the college student. And he was much older, though. And he had attempted suicide by jumping off of a bridge, you know. So imagine a bridge, and up under the bridge, there's concrete. And bridges, of course, they are high. You know, there's a certain distance between the bridge and the ground. And it wasn't one of those low bridges where, okay, you're safe, you can just jump, I don't know, 8 feet or 10 feet and you're good. It wasn't a kind of bridge like that. This was a really high bridge, and he had jumped. And it was amazing that he had survived. He survived the jump. And I remember my work with him, I kept really admiring his spirit, his will to survive. I kept telling him, like, I am amazed that you survived it. And I think you survived it because within your spirit wanted to live. I told him this. I said, your spirit wanted to live. And it's amazing that although part of yourself and your mind had led you to the point of jumping off that bridge, there's still a part of you, apparently, that you had no control over, that said, no, it's not time to go yet. And so you decided to live. He survived it. But did that. He jumped off the bridge because he was diagnosed with a terminal medical illness. And I use this example because it goes to show that suicide can happen in many different contexts. A person can be depressed. A person can just have been diagnosed with cancer, which leads them to feel depressed. A person can be on drugs. A person can have a very turbulent history with bad relationships that develops them into becoming this person with borderline personality symptoms, that where they feel a sense of they don't have control, in a way that a person who doesn't have control gains control is by doing certain things, by doing manipulative things such as threatening to commit suicide, because it gives them a sense of power. So seeing and working with this patient, seeing this patient at the hospital where I worked, he was beat. Literally, this man was in so much pain from falling off of this bridge and surviving. And of course, at the hospital they doped him up and gave him a whole bunch of medication, to help with the physical pain, the physical symptoms. But psychologically, this man needed so much more work. Now, my role at the time when I was working with him, I was just basically doing intake. I was doing a psychosocial and doing kind of like an evaluation to see what was going on with him, to collect his history and his background information, and to get a picture of what led him to do that. And like I said, I remember talking to him and seeing he was jacked up. This man had a neck brace. He barely could move. He could barely, it hurt him to move his body. He was messed up because he had, a failed suicide attempt. I've worked in this field for a long time, so I've been pretty much exposed to a variety of different cases. So those were two examples of patients I worked with who actually attempted suicide. But I've worked with, still do, work with patients who are suicidal. And not only suicidal, you have patients who also self-sabotage, they self-harm, they engage in these very damaging behaviors where, they inflict harm to themselves, so it may not be to the point of killing themselves, but it's still harm. I've worked with kids. I remember working with a group of kids who were wards of the state. They were placed in this temporary residential treatment center where I worked, and ways in which it's amazing to see ways in which people cope. So suicide essentially is a coping mechanism. It's a method that people rely on to get through tough times in life, And it's like, if you have had the brunt of life, you've had the worst hand dealt to you in life, for some people, their way out is to take themselves out of this life, because they don't see any way. They don't see a brighter future ahead for themselves. They don't have within them the ego capacity and the strength to get through it. It's a very tough time for them, so their alternative is to say, you know what, I'm going to end it. It's unfortunate. But in working with these foster care kids, who were placed in this residential treatment center, for a person who is untrained, you come onto the unit and all you see is just badass kids, quote unquote. If you have no kind of clinical training or reference point for understanding what's happening within these kids' minds, what you think is they just badass kids, right? Same goes for people who are not in treatment, From the outside looking in, you see somebody who's a little bit different than you. You're just like, something is wrong with them, or they just a bad person, not even taking into context the background, the environment that has shaped this person to becoming who they are. So I was working with, boys, adolescent boys, some were children, some were as young as 7 years old, who were placed there because they don't have anywhere to go. They don't have a family. Their family abandoned them for whatever reason, whether it was the mother was unfit, couldn't take care of them, or just the family left them alone. They abandoned them. It happens. So many kids are in foster care because they've been abandoned by caretakers. And I remember one kid specific. I mean, I worked with a lot of kids, who engaged in self-harming behavior. I do remember this one kid. I cannot forget this kid because the way he would cope with stress, it was so like it to me. It hurt my heart seeing him do this to himself. But he would go, and in the facility where I worked, it was pretty much reinforced. So we had brick walls, very enforced, strong brick walls, like a prison, and he would go and bang his head hard as he could on the wall to the point where he would make his nose bleed. Because he would also not just bang his forehead, but he would be banging his nose so much to the point where he would make his nose bleed. And seeing that behavior also reminds me of behaviors of clients where I currently work. I'm currently working with adults with severe mental illness. And I have a client, she doesn't bang her head. Well, not this particular client, because there's another client who does bang her head, but it's more like the back of her head that she bangs against the wall. But this client that I'm thinking about, she bites herself. And she has an arm full of scars where she's literally bitten chunks out of her arm as a means to cope, And for years, psychiatrists, psychologists have tried to wrap their mind around this. Like, what is it that leads clients to harm themselves? There have to be some type of benefit, right? That's the assumption. That's the theory. There has to be some type of psychological, physiological benefit where within themselves they feel better. It's like a release. People sometimes wonder, what is it about, what is it within the mind of an addict who goes and uses these very harsh drugs, and they medicate themselves to deal with these anxieties of life and the pressures of life, but knowing that the drug is also harming them, but they still go back and they rely on this drug. So what is it? And if you look at these self-harming behaviors such as biting or hitting, when they do this to themselves to the point where they actually cause injury, if you look at it in the context of that they are activating their pleasure reward system in their brain, that is responsible for pain and pleasure. So when you feel pain, there's a certain system within our brains that's activated that releases certain neurochemicals that help us to cope with that pain. So take, for example, a client who is experiencing stress, and their means to cope with that uncomfortable feeling of anxiety, they decide to bite themselves. In biting themselves, yes, externally it may be painful, especially initially when you first do it, but over time they develop a numbness to it, so they don't even feel, the area of their body where they're biting, they don't necessarily have a sensation of pain in that area. But in biting that part, they are able to trick their mind into thinking that this is how they should cope. It makes them feel good because you think about it, it gives a person a sense of control, something that you have control over. When a person is addicted to a certain drug, you will hear people, because I work with people with addictions, and they will often say that their reason for using the drugs is that it makes them feel powerful. It makes them feel like they are in control because they're able to, number one, decide where they're going to buy the drugs from. to decide how they want to use the drugs, you know, what method or route they're going to take it into their body, how often they want to take it, when they're going to take it. So in a sense, they will tell you they feel like they are in control of this thing. When in actuality, I mean, the truth of the matter is we know that with addiction, it's not that the person is in control. It's more like the addiction is controlling that person, and they have these impulses that they respond to and are compelled to, they have to, you know, what other way other than resisting it and just coping with those withdrawal symptoms, you know, and having to find a way to cope with the anxiety that they're trying to mask with drugs. It's a very complicated issue, you guys. It's not so simple as to say, oh, well, just don't be depressed, you know, just fix yourself up. Just pray to God and he'll fix it. You know, everything will be fine. We're talking about depression is a medical diagnosis. If we can understand mental illness in the context of medicine and not just, behavioral choices, then I think you can help a lot of people, you know, and not only help other people who are dealing with this issue, but you can also help yourself and prevent yourself. Because remember at the beginning of this video, I said no one is immune to these mental illnesses. So being able to conceptualize and understand how depression can manifest itself from a medical perspective, from a biological, physiological perspective, one can be less likely to judge the next person. You know, you would be more reluctant to point fingers at a person, because I can tell you right now, when you consider the symptoms of depression, lethargy, lack of energy, lack of motivation, when you think sadness, you know, when you think of those things, you can think of a lot of people who meet that criteria, people that you know. I can think of people that I know, people that I've been exposed to. That's like, okay, yeah, that sounds like a lot of black people that's in the hood, right? When you think about the people who are unemployed, and I talk about black people because that is my target audience, but you think about the African American population, a number of people who are unemployed and people who so-called live on welfare, people are quick to say, oh, they're lazy. That's more of a behavioral conceptualization of what's happening. But if you really look at it with a fine-tuned lens, and you say, okay, well, maybe there's something else going on. Maybe it's not just a behavioral choice that these people are making to not go to work, to not seek a job or employment. Maybe it's something else going on. Maybe it's more biological. Maybe it's more psychological. They just aren't motivated. If a person does not have within them the energy to get out of bed, let alone go take a shower and put on clothes, how the hell are they going to be able to go to a job 40 hours a week, you know, on time every single day? It's just impossible. So this issue is really important. That's the reason why I had to create this video, because it affects, like I say, millions of Americans. I believe the number is 50 million Americans have been diagnosed with major depressive disorder. A lot of people suffer from this, man. It's not something that one should take lightly. And like I said in part 1 to this video, if depression goes unchecked, meaning there's no intervention, you don't get treatment, you don't try to do anything to help yourself or the person that you know is suffering from this illness, then there stands a great likelihood this person is going to have feelings of hopelessness and not want to go forward in life, because hopelessness is the biggest key indicator. When you look at a person who is depressed and you're trying to determine how likely they are to commit suicide, they stand a greater chance if they have no hope in their future. I know a lot of this sounds like common sense, you guys, but it's not so common sense because sometimes we forget it. People push it to the back of their minds and they forget it. So before I end this video, I do want to kind of address the statistics on the states that have the highest prevalence of suicide in the United States. Alaska sits at number 1. Then after Alaska is Montana, New Mexico, Wyoming, Nevada, Colorado, West Virginia, Arizona, Oregon, Kentucky, Idaho, North Dakota, Oklahoma, Maine, Utah, Vermont, Arkansas. Florida ranks number 18. Can you guys believe that? Florida is number 18. Kansas, Missouri, then Tennessee. Sad, sad, sad. And it's not to say, I know a lot of times you guys think about adults and think about suicide, but you know, children, adolescents commit suicide as well. And then there's this issue as to whether or not people should have the right to end their life, you know, because you do have people who are on their dying bed, you know, they are in their last stages of life. They've been diagnosed with a terminal illness. They know they're going to die. Let's say, take for example, people who have AIDS, you know, full-blown AIDS or cancer. If they know that they're going to die and they're suffering, why make a person suffer? It's about quality of life. Some people look at it like that. Why make a person suffer if a person is suffering and it's their life and they want to end it? Who are we as health professionals or as people working within the legal system to tell a person that they cannot make that choice to end their life? So, I mean, that's where politics comes into play as it relates to mental health. You know, this thing gets pretty complicated. But as it stands, especially in the 3 states where I've been trained. Sorry about that, you guys. But the 3 states where I have been trained in mental health are Florida, New York, and California. Every last one of those states have this rule. On the East Coast, it's called Baker Act. On the West Coast, they call it 5150. But if a person poses himself as a danger to themselves or someone else, they can face involuntary hospitalization where they don't have a choice, you know. They have to go and get help and get treatment, you know. And you have people who work in, you know, corporate America, who work in certain professions where we're mandated to report. I am a mandated reporter. So any client that I'm working with, any client that is under treatment with me and that I notice is a danger to themselves or somebody else, you know, I have to make that report. And it's not something I think clinicians like doing, especially initially, because they're like, no, I want to save my client. But when you think about it, are you really saving them by not making the report? Absolutely no. You're saving them by making the report because you have identified certain characteristics within this person that point towards they need help. Their life is in danger, in immediate danger. You know, where they are really on the brink of committing suicide or even in the act of trying to kill themselves, you know. It's really, really, really a touchy subject. I know some of you guys who are watching this video probably have family members who have, you know, committed suicide. I work with people. I know people who have family members who have committed suicide. I have a professor who has family who has committed suicide. It's really unfortunate, you know, and I think a lot of times, you know, I think the optimistic way of looking at it is to say that we can catch it. You know, we can just identify the signs. If you identify the signs and symptoms, then you can prevent it. But it's not always that cut and dry. Who is the comedian? What was the name of that comedian? Y'all, I'm bad with names. I'm trying to remember. What was the name of that comedian who committed suicide? Robin Williams. Do y'all remember Robin? I was like one of my favorite comedians. He was so funny. I think this man, like his work was so great. I loved his work. He played the role Mrs. Doubtfire in that movie, and he did a lot of movies, you guys. He was a very funny comic. But when he killed himself, like, it's like, where did this come from? Did no one not see the signs? Did nobody not see that he was suffering from something? Most likely depression. No one spotted this out, So unfortunate, because I feel like the man was still kind of young, I feel like he was still in his prime and he committed suicide. And who else? I mean, it's kind of questionable about Whitney Houston, right? Because they said that she overdosed. And if a person overdoses on a drug, essentially they kill themselves. That's suicide. That's a form of suicide. If you overdose on too much drugs, that's suicide. In fact, when a person abuses drugs, that's one key indicator that a person is at risk for killing themselves. They go kind of hand in hand. This thing is really unfortunate. So before I have to go, actually, it's 1:00 over here, Pacific Standard Time, West Coast. So I'm going to go ahead and wrap this video up because I do have to work on my SPSS data file. For you guys who don't know, like I'm actually in the data collection phase of my research study. So I have I met with some of my research participants, collected some data, and now I'm in the process of inputting the data into this program that we use called SPSS, which stands for Statistical Package for the Social Sciences. It's a program that we use to crunch numbers and to analyze our data. And I've already set up my SPSS data file so that when I have new data coming in, I can just plug it into the system. But I have to go and kind of rearrange some of the variables. I left out some of the variables the way my professor wants me to organize it. So I have to end this video so I can go ahead and do that. But I do thank you guys for watching. And I don't want to end this video without sharing with you guys the number to the suicide prevention hotline. So you guys take 1 second right now and go get a pen. Go get a pen so you guys can write this number down. Some of you guys probably already know it, but I want you guys to have this number, because who knows? You may be watching this video right now and you may be feeling depressed. You may need someone to talk to. So I want to give you guys this number. Ready? It's 1-800-273-8255. One more time. 1-800-273-8255. This is the number. It's a hotline, 24-hour hotline. So no matter what time of day it is, it can be at nighttime. Sometimes people feel more comfortable calling to get help at night because they feel like everybody else is asleep, nobody else is going to know, right? So if this is nighttime and you feel like nighttime is the best time to talk to someone, when everybody else, maybe you live with somebody in the household, maybe everybody else is asleep, find a time where you feel safe to talk to someone and make the phone call. Because I have to really address this because there's such a huge stigma surrounding getting help, which is so stupid. It has got to be the dumbest thing on earth that people will think that something is wrong with somebody just for getting help. But my God, if you know that you need help, you do not feel well, something is not right. Nobody knows that better than you yourself. You are living in your own body. So you know what's going on in your mind, in your body. Something does not feel right inside of you. And it's causing you to have these weird thoughts of ending your life. I'm here to tell you, you don't have to end your life. There is hope. And the mind, the brain itself is so flexible, you know? So you can have these terrible thoughts right now, where you're sitting right now, how you're feeling right now. But do you know, over time, with the right intervention, the way that your mind is working can change. You can actually have a brighter future for yourself. You don't always have to feel depressed and hopeless and helpless, and have this fatigue where you're so tired. You don't have to feel that way. And usually when you're depressed, I think it becomes more salient when you go out and you're around other people. So I think as part of the coping mechanism for depression, people withdraw themselves. They isolate themselves. They don't want to be around people. Because if you're around people, then you have a comparison point. You have a standard by which you can compare yourself to, which is sometimes isn't good. Because in your mind, you're like, okay, I feel like this. I'm not smiling. But when I go out and I'm walking down the street, everybody so happy. Everybody walking around and they kissing and holding hands and got smiles on their faces. And that's what you see when you look around, but you don't feel that way on the inside. So that's why for people who feel depressed, being isolated away from everyone else, it's like creating a safe haven for themselves, because they don't have to compare how they feel to some standard out there in the world based on how other people are presenting themselves. But deep down inside, chances are a lot of people that you see walking down the street with smiles on their faces don't really feel that way on the inside. All that is them putting on a front. It's an external front that they portray because they don't want people to judge them. I think we have to get away from that fakeness. Let's stop giving fake smiles. You have people that want to say, okay, if you smile, it'll make you feel better. Just smile. Why are you not looking happy? But my God, if somebody that you see is not looking happy, instead of telling them to smile, maybe understand what's making them unhappy. It's always better to get to the root of the problem as opposed to just brushing over the root of the problem and then forcing someone to fit within the norm, so-called norm, when you got millions of Americans living with depression. And those are just the reported cases. Who knows how many Americans are actually living with depression and just live and suffer in silence with depression. They don't want to tell nobody. They go to work, they try to fit in with the coworkers and act like everything is okay. Nobody knows that they sleep for 10 hours a day or 12 hours a day. Nobody knows that their way of coping with stress and is lethargy and feelings of helplessness and hopelessness. Nobody knows they cope with it by overeating. And they eat and eat and eat. And you look at people who are obese, who have weight issues. A lot of times, what underlies the physical condition is a mental condition. That's called comorbidity, dual diagnosis. People are experiencing more than one issue at a time, more than one condition at a time. What you see on the outside is an obese person, or just a person who like to eat, but something that is giving them the impulse to eat, because eating is a coping mechanism. Sometimes people, they cope with their stress. They cope with feelings of insecurity and low self-esteem by eating, because even eating it's not just psychological, it's biological. When you eat, your brain releases these good feeling neurochemicals are released in your brain that make you feel good when you eat. Why do you think people like to eat chocolate? Serotonin is activated in the brain. Dopamine is activated in the brain when you eat certain foods. Sorry, I got a text message. So people medicate in different ways, not just with drugs. In a way, food can be considered a drug. But people medicate themselves with food all the time. You see people always going and get pints of ice cream, eating, eating, eating. And you're looking at them and you're like, you gain weight. A lot of times it's not the fact that they just love food, but it's something that the food is serving for them. The food is serving as a coping mechanism to make them feel good. Hence the expression comfort food, right? It's making them feel good. That's why they rely on it, you know? And then an over-reliance on food obviously leads to obesity and leads to other health problems because people are choosing the wrong types of food to eat. You know, so people may overindulge in eating sweets and wonder why they have diabetes, you know, because they're not regulating their sugar intake. This thing is it's multi-layered, you guys, you know? So just understand that this thing is a serious topic, you know, and it's unfortunate that there is a stigma in our society around mental illness, but I feel like if only we can get to the point where we can make it, not that we normalize mental illness, because that can have drawbacks too. I mean, on one hand, the advantage to normalizing mental illness is that, okay, you make people feel like they're not alone, that other people out there in the world have this issue too, go through the same things too. So if you know that you're not alone, you're not going to feel as bad about your problem. But on the flip side, normalizing something such as mental illness, you making it like it's an end thing, like it's cool. So it's cool to be bipolar. It's cool to be depressed. It's cool to have anxiety, you know? Just go and talk to your psychiatrist and get a pill and pop a pill. Now everybody's on anti-anxiolytics, anti-anxiety medication, essentially, you know, because they think it's the end thing. Everybody doing it, so I'm about to just go and call them out there. It's just like, you don't want it to normalize it and make it to be the end thing, but we want to normalize it so that people can understand they don't have to suffer in silence. You don't have to suffer in silence, you know. Your body, your health is the most important thing that you will own. You own your health. You are in control of your health. That's the most important thing that you have. It's priceless. It's the most valuable thing. It should be anyway, because without your health, how can you survive? You know, how can you live a quality life without good health? So that's important. And we have to get to the point where we can actually be able to have roundtable discussions and talk about mental health. Talk about what we're experiencing. You know, have private group discussions where we can come together and we can all go around the table and talk about, you know, the kind of day that we had at work or the kind of week that we've had, you know, and how this has impacted our mental health and our emotional well-being, you know, the choices that we've made, so that we don't end up isolating ourselves, feeling like, oh, it's just me, something is wrong with me, so let me separate myself from the rest of the world because I don't want to be a burden to the rest of the world. So let me just separate myself and go into my cave and live lonely. Human beings are not designed to be isolated and to be living lonely. We're designed as social beings to be interactive with other people, to exist, to belong. You get what I'm saying? So sometimes you can exacerbate, you can make your condition, these symptoms that you're experiencing, worse by isolating yourself, by suffering in silence and saying, I'm not going to reach out to get help. I'm not going to talk to anybody about this, you know? But I gave you guys the number to the suicide prevention hotline. That's one resource that you can use. And that's if you're contemplating suicide. Now, if you're experiencing depression, you know, or something, let's say like anxiety, you just need somebody to talk to, then 211 would be a great resource. That's the hotline where I used to work. It's a national hotline now. So it should be in every state. So no matter where you are in the U.S., you have a cell phone or any phone, you can pick up that phone and dial 211. Now, it varies state to state. When I was in Florida, and I was living in Tallahassee working at 211 Helpline, we did crisis counseling. So it was more than just a referral resource where people call it get referrals. We actually did counseling. We talked to people and talked them through their issues to the point where they can get, we give them the numbers to different agencies and they can go get some help. So you would definitely, I think, if you're looking for someone to talk to, and this is free, by the way. I should have said that at the beginning, but this is free help, you guys. You don't have to pay for it. You should, I think the issue is that sometimes people, they have these significant problems, and yes, you have a friend. You have friends, right? Friends serve a purpose, but friends are not trained as clinicians. And sometimes friends aren't as objective as you want them to be. You're looking for somebody to be non-judgmental, but your friends going to cast judgment on you. They're going to be like, oh, child, you'll be all right. What you complain about now? You get what I'm saying? Sometimes they don't know how to handle what you bring to them. You can really be feeling severely depressed. Or you can, let's say, be feeling like you don't even feel like you're having a real experience, like you're having some out-of-body experience. You don't even feel like you're yourself no more. Try to go and tell your friend that, who thinks that you're just this upstanding, normal person in society who has it all going for herself and who's all good, or a guy who has all these things going for himself and nothing is wrong. Try to go to your homeboy and tell him that you feel depressed and see how he gonna respond. A lot of times they're gonna just be like, child, please get out my face. Oh man, you'll be all right. Just go work it off in the gym. Go get some pussy. A lot of times people think that, especially within the male, community, men will tell other men, oh, just go, go get you some pussy. You'll be all right. Get you some pussy. And that's not necessarily the solution. I think a lot of times, unfortunately, men are dealing with a lot of stuff psychologically, emotionally, that they turn to sex to cope with. And they use different women as these objects to help them cope with and get through these issues that they're dealing with. So that's the reason why we have professionals, people who are trained. They have a good number of years of experience doing the work that they do, and they are licensed. So they're held to a higher standard. They're not just some regular Joe Schmo on the street trying to do some freaking saying they're going to read you your tarot cards or something, psychic. Pastors have a certain level of kind of training, or from a spiritual point perspective and a religious perspective, which could be good, but sometimes pastors and churches fall short in being able to effectively and appropriately deal with people with mental illness. That's just like trying to go to church for a physical ailment that you have. You get what I'm saying? When you need to be going to the doctor. Let's say you take a female or a guy who know they've been sleeping around sexually, having sexual intercourse with people, no protection, and now you got some rash between your legs in your genital area. But you decide you're going to go to church and pray about it and have church fix it. That's not necessarily the right type of intervention that you need. You need to go see a doctor who is trained and licensed to treat exactly what you're dealing with, because they've seen and worked with so many cases just like yours. So you got to make sure that you're going and getting the right intervention for whatever issue that you have. If you got a psychological issue, even the church, like I was saying, is not necessarily trained to deal with mental health conditions such as schizophrenia, such as bipolar, depression, paranoia. A lot of times the churches say, oh, let's just pray about it. And yes, the benefit to going to church and prayer is that it does have a psychological component, a healing component to it, because it's like, in a sense, you are being able to share what's going on inside of you with another person who is able to hear you and identify with what you're going through. But that's only part of therapy. You get what I'm saying? Therapists do the same thing. That's just part of what we do as therapists. There's a lot more work that needs to be done when you're talking about a person who is dealing with depression. You need more than just somebody who you can talk to and who will listen to your problems and hold your hand and say these positive affirmations to you. Therapy takes what they do in church and they take it a step further and go beyond that. Treatment is much more involved if you go to see a licensed therapist or a licensed psychologist, which I'm training to become. So that's something to keep in mind when people think that, okay, I'll be good, I'll just go to church. And just like depending on the severity of what you're experiencing, I would say church might be appropriate for mild stuff and even mild conditions. If you got, a little bit of depression or a little bit of anxiety, the church may be able to help. But I would say still, you can't play Russian roulette with your life. People don't understand the significance and how this is mental illness is really big, you guys. It's not as cut and dry as, oh, I'm feeling depressed, I'm just feeling sad, so I could just go to church and get a tambourine and just clap my hands and I'll feel better. That's not how it works, you guys. We're talking about something that has a neurological base in your brain, that your brain has now been rewired to function a certain kind of way. There's a lack of something in your brain. There's a depletion. Church ain't going to fix that. It might put a little Band-Aid on it a little bit, but it's not going to fix it. So that's just something to keep in mind. I got to go. I'm not going to keep you guys for too long. But I encourage you guys to share this video on your page, please, because there's somebody who may need it. You may feel like you're good. You don't need to hear this. But there's somebody who does. So look out for other people in your network, in your community, and share this video because there's so much information I talk about in this video that I know can be of help to other people. We're just human beings at the end of the day, having a human existence, on this earth with the time that we have. And life is hard. Life is a struggle for everybody. Nobody has a scot-free life where it's just everything is peaches and cream and it's all good. Everybody has things that they go through, and mental illness is just a reaction. It's just a response to stressful things, tough things in our environment that we've been exposed to. And if it's not in our environment, sometimes it's passed down through generations, genetically. It's just a response to those things. A lot of times you don't have any control over it, that response. So it's not your fault that you feel depressed. Don't let anybody tell you, oh, well, you need to just do this, you just do that, as if it's something that you did do or didn't do that caused you to feel depressed. Get what I'm saying? Don't take it and feel guilty. But a lot of times, unfortunately, even guilt is one of the symptoms. I didn't mention it, but it is one of the symptoms of depression where you feel guilty. And that's so sad, that people feel guilty for their mental illness, because it's like a lot of times it has nothing to do with you. Even if you are an alcoholic or you are an addict, a drug addict, it's not something that you should feel guilty about. It's something, unfortunately, you have to take responsibility for. But if you really understand how addiction takes form, you'll be able to feel a sigh of relief that a lot of it is really out of your control when it comes to how you've been predisposed to this thing called addiction. It's a beast, man. And a lot of it is just genetics. It's what you're exposed to in your environment, Peer pressure can be a factor, And people, it's not just as simple as saying, oh, stop using drugs, or stop hanging out in this neighborhood, It ain't that simple. So I'm about to end this video because I got work to do. But thank you guys for tuning in. Thank you guys for watching. And I'm going to probably do a part 3 to this video because it's so important. Like, I have a lot of different topics that I want to cover with you guys as it relates to mental illness. I'm going to come back on here and talk about narcissistic personality disorder. I think that's really important. It's a big one because a lot of people are looking at Donald Trump, our president, like, this man, he got some mental illness going on, And this stuff is mind-blowing. It can be pretty mind-blowing, pretty amazing. So I want to come back and talk to you guys about different types of personality disorders, including borderline personality, histrionic personality disorder. You have bipolar is a really major problem. That's a mood disorder that people, unfortunately suffer from. And a lot of African Americans are diagnosed with bipolar disorder, A lot of African Americans are diagnosed with schizophrenia, where they have these cognitive distortions, and a lot of times there is some psychosis. So they see and hear and feel things that aren't there, And some of this, think about mental illness, like this stuff happens on a progression. So you may have, it may start off as something kind of minor, but unchecked, you will have a person who has something that was much easier to treat, such as anxiety, for example, or depression. They could have got treatment for that, but they having this stigma surrounding mental illness and going in for treatment, they back away from it, and then that mental illness transforms into something else. So what was depression, what was anxiety, turns into something much more severe that now you probably going to need some medication to treat. And not just medication to treat, but you're going to be on it for the rest of your life because you did not take the proper steps, precautionary measures to prevent something that was much more manageable. You've allowed it to take this new form. Because that's what the mind is a very complex organism that we have. It's a very complex thing. It's like the mind itself is a concept, linked to the brain, but it's a very complex thing. And people don't understand that mental health is important. Like they say, the saying goes, a mind is a terrible thing to waste. I cannot emphasize that enough. A mind is a terrible thing to waste. Your health is important. Makes no sense how people will go to the doctor and people will brag about going to the doctor and I went to go see my doctor, my physician, my medical doctor, but then shy away from going to see a psychologist who is also a doctor. You get what I'm saying? They're a doctor of the mind. Your physician, your medical doctor is not trained. He does not, they get exposure a little bit to psychology, but not to the extent that we do as psychologists, So it's important that you have a doctor who can meet you where you are. If you know that you're suffering from depression, yeah, you can go see your physician. They can give you some antidepressants. That's pretty much the most they're going to be able to do. They're not about to have talk therapy with you. They're not about to go and have these really deep-seated therapy sessions with you where you can really face your demons of your past and uncover some of your most deepest, darkest secrets, and work through those defenses. A physician, a medical doctor is not going to do that with you. Neither is a psychiatrist, by the way. But a psychologist will. A therapist will, So that's the thing. I can go on and on and on about this, but I just want you guys to just take care of yourselves. Make sure that not only you take care of yourselves, but look out for your friends and family. If you see something is not right, judgment is the worst. Don't take that approach to judging a person because all that's going to do is make them shut down. So you don't want to cast judgment. You don't want to point fingers. You don't want to make jokes about a person if you see something a little off. You want to express concern towards that person, empathy towards that person. Try to put yourself in that person's shoes. You get what I'm saying? I think that's what makes a very good therapist. People tell me this all the time. Like, you can be a very good therapist because, number one, I know I've been through a lot of shit myself. So now I have a client sitting across from me and they're struggling with all these issues, depression. I'm looking at them and kind of seeing a mirror image of myself, seeing a reflection of myself. you know, so I can have empathy. It's easy for me to empathize with people who are suffering with mental illness because I know the struggle that I've had in my own life, you know, just coming through life as an African American woman living in America. You know, it's tough out here, you guys. So I gotta go, but I'll catch you guys in the next video, and I hope you guys were able to get blessed and benefited from watching this video, and make sure that you shared it if you do. Thank you guys for watching. Bye.